Welcome to CMS on Hospital at Home, the Acute Hospital Care at Home, or AHCAH Waiver Study, and the Future of the Field, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and the webinar series. The Hospital Home Users Group is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and payment policies necessary to build the field and spread this hopeful, person-centered model of care. Please visit our website and be sure to check out our TA Center for helpful hospital at home program resources and tools, as well as our recently refreshed research center. This is the 26th in a series of webinars that we have produced through the Users Group. These are some of the topics that we've covered here. We encourage you to find a topic you may have been thinking about or working on and take a look, or if you have a lot of time on your hand, you can just binge all of them at once. Finally, a team of researchers at Mount Sinai is looking to interview hospital at home caregivers for their input on the caregiver experience and a range of equity issues related to hospital home policy, research, and practice. And we need your help to connect to those folks. And to get involved in the study, simply scan the QR code here or contact info@hahusersgroup.org. It's now my pleasure to introduce our moderator for today's webinar, Ray Quintero. Ray is a managing partner at Healthsperian, LLC, with nearly 2 decades in healthcare public policy, legislative, regulatory, grassroots advocacy, communications, and political experience. As managing partner at Healthsperian, Ray leads a team of experts who specialize in developing in-depth legislative and regulatory policy strategies, analyses, and strategic advocacy and communications for a wide range of healthcare organizations, including the Hospital at Home Users Group. In this role, he's been a valued partner for the Users Group, and we're really pleased to have him moderating our discussion today. So please, Ray, take it away.
Great. Thank you so much, John, and thank you to the Users Group as well as to the John A. Hartford Foundation. Good afternoon to everybody. It sounds like we have a great amount of participants, which is wonderful, especially for webinar number 26. So thanks again for the invitation, and I'm really thrilled to moderate today's discussion with a wonderful and distinguished group of panelists. They truly don't need any introductions. However, I will say a few words about each of them before we jump in to what we hope will be a lively as well as informative discussion for everybody. Our first panelist today is Dr. Lee Fleischer, who's Emeritus Professor and former Chair of Anesthesiology and Critical Care at the University of Pennsylvania. Lee also serves as Senior Advisor at Faster Cures at the Bipartisan Policy Center and is a visiting fellow at the Duke Margolis Center. Lee was importantly the Chief Medical Officer and the Director of the Center for Clinical Standards and Quality, better known as CCSQ at CMS from 2020 to 2023. So right in the heart of the pandemic, as well as when the waiver was being written and implemented. Our second panelist is Nancy Foster, who's the Vice President of Quality and Patient Safety at the American Hospital Association. Nancy leads efforts to improve quality and safety, and she works really hard at the AHA to advise CMS on quality measures and their application across programs. And in her collaboration, she works with experts to translate the safety research into improved policies, as well as practices affecting quality of care. Lisa Tripp is our third panelist to round out the group, and Lisa is a partner at Tripp Hollander Advisors. Back in 2020, Lisa was appointed to the CMS COVID task force, and she helped draft the Hospital Without Walls waivers, and then she co-led the team that wrote and implemented the CMS Acute Hospital Care at Home waiver. So Lisa was also right in the mix of it, and after leaving government back in 2021, she led advocacy at Medically Home, where she was instrumental in getting Congress to extend the Acute Hospital Care at Home waiver in 2022, but then she also helped to get the House as well as the Senate to introduce bills for the 5-year extension that's currently on the table. for the waiver in 2024, which is coming up upon us in just a few short days. So as we think about today, during the brief time we have, we want to focus not only on the waiver itself, but the waiver study that CMS had and the course that it's going to take in the future of the field. As a reminder, Congress acted at the end of 2022 to extend the waiver until this December. That's a short 40 days from now when this current waiver is going to expire. So Congress has to act in order to extend it. But of course, in order for them to do that, they need a lot of information. They need to make decisions. Obviously, they're back from elections. They're ready to go home. Many are ready to come back and hit the ground running in January, but there's still work to be done, one of which is to determine what to do with this waiver that is set to expire. But as part of the last extension that occurred back in 2022, they were required to report to Congress, and they had to report to Congress by the end of the fiscal year, which came in September. That time came and CMS delivered. They delivered that report. And in that report, what Congress wanted to hear is they wanted to study multiple areas, and they wanted to study areas that some of which Congress was skeptical about, some and even CMS may have been skeptical about. They wanted to compare what hospital at home was doing, similarly, what was occurring in acute inpatient settings. And what they wanted to understand was what quality looked like, what conditions were being treated, what costs looked like, what services were being provided, the quantity of services, the mix of services, the intensity of services, but also they wanted to understand the demographic and socioeconomic data of the individual patients that were being cared for under the waiver that was put in place. They wanted to understand the race. They wanted to understand the ethnicities, the income, the dual eligibility of certain patients. So what they really hoped for with this particular report was that it would, of course, be unbiased, that it would be neutral, and that it would be based on facts. And that's what ultimately was delivered to Congress by CMS. And overall, what this is going to be used for is so that policymakers can understand who hospital at home patients are that are being served, particularly under the waiver, and to ensure that safety is akin to the safety that's being provided in brick and mortar hospitals. And of course, that's fair. It's fair for Congress to ask those questions. It's fair for CMS to understand that about a waiver that they are operating. It's fair for all of us to ask those questions. And it's also fair for us to have that discussion today. So today we're going to spend our time again discussing the report, its findings, and views on what those findings mean, not only in what the data showed, but what it means in the broader context of hospital at home, but also for the future of hospital at home. So why don't we just jump right in with some questions? I'm going to start with you, Lee, with the first question. So of course, one of the takeaways of the report is that acute hospital care at home patients experience a lower 30-day mortality rates compared to their brick and mortar hospital counterparts. Of course, I'm summarizing here. Fewer hospital acquired conditions, lower readmission rates, and less complex respiratory and infectious conditions compared to those in brick and mortar hospital inpatients. Considering your background, of course, leadership and quality, from your perspective, does this tell the whole story of the waiver experience when we think about quality?
Well, thanks for the question. And, you know, when I was still in the agency when the request came in for the study, and we had a lot of discussions. And the key thing is the waiver was created, and the report clearly states this. And I really give the authors of the report a lot of credit that this was developed, the waiver, in an emergency situation. I'm sure Lisa can reiterate the 7 infamous days in November of 2020 when I was directing the team that Lisa and Doug eventually led, of how we created that waiver and why, and the appropriate selection of who entered the waiver. There are only 300 and nearly 400 hospitals out of 6,000 acute care hospitals who are in the waiver. The team actually turned down, or actually they never turned down. The team required the hospital to truly be prepared for the hospital at home and to enter patients into it. And they would spend several weeks until they felt the team was ready. And actually, in the end, I had to personally approve until I left the agency every single waiver, so the team would discuss it, the clinical implications. So what I can say is, for the hospitals that entered the waiver and for the patients they enrolled in the waiver, the outcomes were at least as good using a propensity type of matching to patients in a hospital setting. So in my interpretation, it doesn't say it's safe. What it said is the way the waiver was constructed and implemented by the hospitals that did it, they deployed it in a very safe way, which I'm very proud of. And I think the hospitals who did deploy it deserve a lot of kudos. So I think when you put in all those caveats, and the other thing that is critical is every hospital had to report to CMS any bad events, and they were distributed out. So given that, the answer was this was a great program that delivered another type of care for patients who needed hospitalization that had similar outcomes. Although it reached statistical significance, the ability to match patients at the level to which you could really say they're same, it wasn't a randomized trial, did as well or better in a lot of outcomes. How that would generalize is really the question that I think any extension needs to proactively design into the study.
Mm-hmm. So would you say, taking it a little bit further, that because the outcomes, just to paraphrase what you said, were at least as good, that one could potentially, if plain devil's advocate, could say that there could be some, maybe because of the design of the appropriateness criteria, some maybe cherry picking, lemon dropping going on within a hospital at home because of that criteria compared to a traditional inpatient unit?
We had to actually explain because they kept saying selection bias. That's actually what every hospital does. They decide who should go into which ward.
Right.
They have staffing ratios on different wards. They decide who goes in. I mean, I'm still practicing clinically. At the end of a case, and I mainly do outpatient, I will say, yeah, the patient can go home, or no, they shouldn't go home. That's a decision. So I think what it showed is that the hospitals made appropriate decisions as to which ward they should go to, one of the wards being home. I really don't say they should go home. They really, to me, it's a ward extension of the hospital.
Great. Shifting to costs, Nancy, the report also showed that under the waiver, episodes had longer lengths of stay, typically by about 1 day or approximately 1 day, and resulted in lower Medicare spending, on average about 22.1% less in spending, and that during the 30-day post-discharge period for most of those diagnostic categories. While acute hospital care at home patients also utilize both in-person and telehealth services, the overall cost per episode was lower than traditional hospital stays. From your perspective, do you think this data would, in a sense, pit traditional inpatient care against hospital at home, or does it convey how the two can work in concert, kind of going in line with what Lee was just mentioning about there being a decision on where a particular patient should sit?
Thanks for the question, Ray. And I'm really glad I followed Lee, because I think what we're both communicating here is that we have a select group of patients. And CMS has done a remarkably good job in this report of using the available measures to try and give us some insight into both quality and cost, but they're imperfect measures. And so what we can see here, they couldn't look at how much they paid for a hospitalization, because by decision of CMS, they were paying the same amount for an inpatient stay in the bricks and mortar facility as well as in the home. So they really had to look at that 30-day post-hospitalization period to know whether there was any substantial difference in cost. They could have looked out 60 days, but then it gets a little fuzzier. So they, the fact that they looked at 30 days, found a difference, despite patients staying a longer time in the hospital at home bed, they did find that substantial difference in post-acute care utilization, whether that's at a bricks and mortar facility of post-acute care or through telehealth or other services. That's important to understand and a really good finding out of this report. But it doesn't actually tell us really what the differences are, because what we know from talking to hospital at home programs is that there are different ways in which they spend money. And when we get to that question of what's the appropriate amount of money to be spending on a hospital at home patient, I think there's still going to be some outstanding questions that Congress will have that we're going to have to be able to answer. And that's going to require a deeper look at exactly what's being expended and why, and how does that relate to the selection of patients that you were just talking about with Lee. So a lot of things going on here, hard to separate and say just because they found less cost in that post 30-day period, thumbs up, we've won the cost victory here. It's a good indicator. It's a promising indicator, and it is similar to some of the findings from the earlier hospital at home studies. So I have every confidence that we can find a difference in expenditures. Exactly what contributes to that, how we should look at that, I think requires some deeper understanding and deeper study.
It's a good point that you make in terms of there is consistency certainly with what was found in not only this report but earlier studies of hospital at home. And as we also think about the indicators, we do want to, and I'm going to shift to Lisa on this one since she was there at the time also when the waiver was written. We do also want to think about what the original intent of the waiver was. Past his prologue, so we want to think about kind of what occurred. So Lisa, as we think about when you were there when helping lead in the development of the waiver, and the report notes that this was originally, of course, created as a pandemic waiver program. They make sure to say that. Do you think the CMS report data reaffirms that original intent, or is there another story here considering the report and the context of and the history of hospital at home overall that we can think about?
Yeah, thanks, Ray. I appreciate the question, and very happy to be here. Scary when you follow Lee and Nancy because you don't want to misstate something that they have already stated so eloquently. So forgive me if I am less precise than they are. I would say a couple of things. Number one, going a little bit back into the history of how we got here. There was a time period in March of 2020 where there was a lot of activity at CMS. We did tons of waivers. And then at the time, that administration, after that, April, May, was really more focused on reopening and getting back to normal. At that same time, Medicaid agencies in Massachusetts and in California kept asking CMS, can we please do hospital at home? Can we please do hospital at home? Because their beneficiaries, there was no place for their beneficiaries at a hospital. So because we kept getting these incoming urgent requests from these Medicaid agencies, we were able as a team to continue to look at, is hospital at home a good idea at all? And we frankly didn't know. We had no idea. And so we had the fortuitous occasion of having Doug Clark join the agency, and then he was detailed over to our team. And then Doug really led in earnest the evaluation, looking at all of the literature, talking to people like Bruce Leff, Linda DeSherry, David Levine, Al Su, Colleen Hull, many other folks, and really over these months, figuring out, does the data that we have available to us and the people we're talking to, do they think this is a good idea? Do we believe it's a good idea? Is this model of care safe? And it was really mostly it. Is it safe? And so when the big national first national COVID wave hit in October and November of 2020, we were ready. As Lee mentions, we had done all of this legwork to be prepared in case if it was needed to go forward with this waiver. So at the time, as Lee and Nancy indicated, and as the report clearly says, this was a capacity issue, right? So in terms of the waiver fulfilling its stated intent, adding needed capacity in the middle of this maelstrom, I think it achieved. But I think owing to the longevity of the model of care, primarily abroad, around the world in many other countries, I think that the fact that this is the only surviving individual, it's the only individual waiver we did across the board at CMS for COVID. And in addition to telehealth, it's one of the few that has lasted beyond the end of the public health emergency. And I think that speaks to the quality of care that has been received, the popularity among patients and caregivers, and frankly, we shouldn't lose sight of this. Many hospitals, many markets have either a tremendous overcrowding problem, and in rural areas we have, and in some suburban areas we have a closure problem. So if we want to think in the future, and I think Congress is doing this, what else can we do to efficiently add capacity? So it's a long answer, but the capacity was a problem then. Capacity is a problem now. And so this is responsive to that urgent concern in a way that I think the data shows is fundamentally safe, with all of Lee and Nancy's caveats.
Great. You know, it's interesting, Lisa and Lee and Nancy, some of the problems that we saw pre-pandemic, with capacity and during the pandemic, there's still issues that we're facing today, and issues that, there were safety issues. I mean, everything that we're talking about today, that the waiver is helping to solve for, can continue to solve for. And, one thing that, I'd like to hear from each of you on is, as we think about the report itself, one of the statements that it made, and I'll quote from the report, is that it said many of the results, and again, many of the results from this study appear consistent with the intentions of acute hospital care at home, including the delivery of safe, quality inpatient care in the home and alleviation of strains on brick and mortar hospital capacity for appropriately selected patients, unquote. That's exactly what we all talked about. So rather than analyze that statement, I mean, it says what it says. What do you think the future of hospital at home looks like, whether it's within this waiver or even beyond, based on your own perspectives?
Should we just jump in?
Jump on in, Nancy.
Oh, thanks, Ray. I know it didn't sound like it when I answered the first question, but I'm a huge proponent of hospital at home. As Lisa has said, it's, and you said in the introductory remarks, Ray, it has huge support from patients and their family members and from staff and a variety of other folks. As you were alluding to, we have now, and I anticipate we will continue to have, a capacity problem in America's hospitals, in part because of the aging of the population and the propensity for older folks to need more hospitalization, but also because of the staffing challenges we have right now and continue to have. So if we can entice people to stay in healthcare, delivering healthcare by being able to do it sometimes or for most of their remaining career as a telehealth kind of function, or in visiting the home, being one of those nurses or doctors that goes out to visit the home, that's wonderful. Let's keep them. We need all the help we can get. So there are a lot of reasons to think that this program can and should continue. I don't think that reduces the need to continue to learn here, because there was a limited there were limited types of patients who were admitted to the hospital at home program. I think, and I've heard many who are far more expert than I comment on the opportunity that exists to expand hospital at home to many other kinds of patient populations. So lots of area to explore and to continue to grow this.
Lee?
Yeah, so yes, I am a fan with probably more caveats. And I was asked when the new administration came in and you know, what would be the best approach? And if this was in a total cost of care model, I think this is a phenomenal model to use, because if they're responsible for saying what's the best level of care for an individual patient, if I assume the total cost, you're in, you know, Maryland, for example, then that ensures program integrity, because having overseen the home health, hospitals, and other facilities, my concern is that it won't be implemented in the 6,000 hospitals in the same way. So how do we construct a program that ensures that the beneficiaries receive the care they deserve and that the trust fund is appropriately protected? Because as I think when I wrote something on this, this is a phenomenal option if done appropriately. That, and getting back to Nancy's comment and Lisa's comment, patients love it, and therefore, and so many staff love it, and there are lots of good options to embrace this. So it's actually important that as people think about how they tell the story about the hospital at home, and when we heard what Congress wanted in part, some of which was informed by technical assistance given by CMS, some of which, as Nancy appropriately said, they could never get to total cost in the hospital itself. They wanted to understand, in fact, they initially asked, you know, what number of hours do you have that a nurse goes into a room? Well, that's so variable depending on the severity of the patient. It's that safety net. So I believe total cost of care would be great, as opposed to a fee-for-service program, which we have to figure out the right concerns. And I truly believe in, and Lisa may remember this, that we actually made the CMO, CEO, or CNO of every hospital sign that they understood that this was done under the conditions of participation, so that we ensured that they had a very robust quality assurance performance and program improvement program to ensure that quality is truly outstanding.
Lisa, do you want to build on that?
Yeah, just, and I won't repeat what everyone has said. I think you asked sort of a forward-looking question, right, Ray? So in my personal view, I would love, as Lee said, this is basically the hospital ward at home, right? And so the team used to call it the H floor. You're going to send this patient to the H floor, which was the home floor. So what I would like to see in the future is a hospital at home that was more than just the ward. For example, emergency care at home, and things that we could do safely to keep patients from still under the auspices of the regulated entity, the hospital, but ways in which we could right now the waiver is limited. It requires every patient to go to the emergency room. It requires or be admitted already to the floor. I would like to see a future where we enabled our paramedics in partnership with virtual forward physician care, such that we could have appropriate patients seen at home and not brought to the emergency room if they don't need to be, but still under the high quality care, again, owned by the hospital under the conditions of participation. So that others on the panel may see that differently, but that for me is how I would like to see this develop, in part, and I'll be very honest with you, in part because that's what I would like. I would like, if I had to call 911, I would like my paramedic to be adjacent to a physician who was virtually available to me. And if we could problem solve my condition without me having to go and wait in an ER for hours and hours and hours, and tie up that emergency resource for hours and hours and hours, like we do in so many places now. If we could do that safely, that's what I would like the future to look like. So I see this as a starting point.
So I'll have some fun because I remember these debates with Lisa. And as the practicing clinician as the anesthesiologist who oversaw a critical care unit, what worried me the most is we don't have true interoperability here in this world. We don't have EHRs at home. We don't. So part of, and this is actually the challenge of the hospital at home group, as they think through this, and as you think through what the future is, in a world in which everything that's happening at home, the Internet of Things, actually, that the patient, if there was a way, in part, besides program integrity, where the intake in the home was identical to the intake in the emergency department, that it immediately went into your EHR. I still remember when people would look up, oh my God, the patient was admitted from the OR. We don't know how to get into the OR record when we get to the ICU to see what happened in the OR. That's a bad clinical situation.
Sure. Yeah.
And go ahead.
I don't disagree. And what I believe is happening is that future where we have true interoperability, where you can have an inpatient level record at the ready. That is, I think, where, or at least a record, however you want to label it, that would allow folks to get the information transferred that they need to get in the amount of time they need. There are a lot of people working toward that, as we speak. So my hope is that we get there. But as the lawyer, the lawyer in the group, or one of them, what happens a lot is you have a lag between the law. The law is so far behind the technology, so far behind the innovation curve, that the law often is the biggest problem. And let's be clear, none of us would be having this conversation at all, but for the happening of a global pandemic. So I want to see, I don't disagree with you about the safety concerns. I really share them, and I see you. But I don't want the law to keep holding back innovation. And I would say, no matter what our concerns are about a future state, we have to ask ourselves good questions. Is the current state tolerable? And hospitals look like MASH units. They look like war zones right now in numerous places. So I would say that is also fueling the urgency that I have to see a new way forward.
And a global pandemic, Lisa, that propelled 373 hospitals across 39 states to establish these programs, despite the fact that one of the other big conversations that's been happening for many years now has been about caregivers, and rightfully so. And there's been a lot of trepidation, again, about caregivers. And yet this report showed that the feedback was primarily positive, not only patient, but also caregiver experiences, with most patients noting reduced anxiety, better recovery at home, improved communication, greater involvement in their care. Do we think this is a victory in terms of our work with caregivers? Do we think there's more work to do here? Because again, there was a lot of concern about caregivers, and rightfully so. But are we beyond that? And can we start looking at caregivers in the home setting similar to the way we look at caregivers when we think about traditional inpatient units?
So it's funny, before Nancy even met me, which was a long time ago, but I did a study where I looked at the transition from inpatient laparoscopic cholecystectomy to outpatient. And I still laugh about the fact that I gave an interview for the Chicago Tribune, and they repackaged it in the National Examiner. And the headline was, "Men want to go home, women want to stay in the hospital." And the rationale, and what we heard in a patient preference study, was actually men knew that they would be taken care of once they got home, and the women knew they weren't going to be taken care of once they got home. Why I'm telling the story is, if you actually read the report of who selected to do this. And we actually, and Lisa did a great job in the team in requiring family consent, that if, for me, I can take off if I had a family member who needed to come home. And I think we need to figure out what the implication. So I think for those who can both afford to take off and are comfortable taking care of the person, not medically, but also getting them back to the hospital, dealing with, you know, I actually think we require meals to be delivered, but I bet you most of the time, and hospitals were great, but most of the time, I'm sure the family said, we don't want your meal, we'll take, you know, our home. So I think we're at a transition of, for the right patient and the right caregiver, this is fantastic. That's why we need to go forward, but we have to realize who that leaves behind.
Lee, that's such an important point, and I would like to augment it with just two thoughts. One is, I think we have severely underestimated the amount of stress that caring for someone who is in a bricks and mortar hospital room puts on family members. We don't have good, accurate measures of that, but you know, in some sense, it's easier for everyone to be at home as long as the burden that the family member is taking on is not something that overtaxes them. You know, helping a loved one to the restroom if that's necessary and so forth. Those things are appropriate for some people, but not for others who might be the caregiver. Secondly, I think you've really hit on an important point here. One of the things that we see in the report is this notation that it was not equal in its application to all patients. And in part, that was the selection criteria, but in part, it's this who has somebody who can stay home with them, who can afford to have someone take off from their work, who as well as whether Medicaid was covering it and a whole bunch of other things that tend to be disparate along race and ethnicity and other lines. So there are lots we have to understand more about the impact on families. But Ray, my answer would be, this is, for many family members, this is a better deal than having to schlep to the hospital and sit bored in a hospital room all the time.
Oh, yeah. And I would also say, like, Ray, first of all, this is an important question. We are a nation of exhausted people who are caring for their loved ones. And it is I respect and value all the voices who raise this issue. And I think it's really important. I would say that what I often say what Nancy just said, which is essentially, it's really important to look. I would not prejudge. I wouldn't say burden. I would say experience. What is the experience of the family caregiver, rather than using the word burden at the outset? But importantly, let's evaluate that. But importantly, what about the families that they don't have the gas money to put in the car to drive to the hospital? They don't have the parking money to pay to go to the hospital. They work the types of jobs where they couldn't go to the hospital if they wanted to during visiting hours because they have to work. Multi-generational families where the person who is hospitalized at home can still be there in a way that allows a working person to go to work. And we hear that when we talk to folks. So I think it's important, if we're going to look at burdens or potential burdens, we should look at the burdens that are imposed when our loved ones are in brick and mortar hospitals, because those are very different depending on your socioeconomic status. And that deserves a lot of attention.
I'm going to use your language as well, Lisa. The experience, you know, sometimes a newer innovation, not that a hospital at home is new, but a newer innovation like this opens up that opportunity for us not only to look at the experience of caregivers for those that are being treated in the home, but also those that are being cared for, to your point, Nancy, in a traditional unit where we're not necessarily asking those same questions about the caregivers in a traditional hospital inpatient unit. So let's have that broader conversation and keep that going. It's important. Lee, were you going to jump in?
Yeah, one of the things that was created as part of the waiver is you could be transferred to the home ward, to the bed at home, after a day or two in the hospital at any time and still be under the DRG. And in many ways, I thought that was sort of the ideal situation. Having recently taken care of an elderly family member in a hospital, you know, he stayed there several days, that I'm not convinced that being home wouldn't have been better with the hospital still providing all those resources. So I think the waiver, in the way that Lisa and Doug and the team created it, allowed that flexibility. And I think that's one of the things that we should try to implement.
And we have several questions coming in on the chat, but before we shift there, I do want to touch on one more here, since the topics come up a little bit about individuals and who they are, where they come from, where they live, maybe their socioeconomic status. But one of the things the report specifically said again was that these patients that are being cared for in the home or on the H floor, as Lisa put it, are meaningfully different compared to traditional inpatient populations. And we've talked a little bit about, based on the inclusion and exclusion criteria that hospitals were allowed to establish originally under the waiver, based on their capabilities and their resources. How can we address and/or course correct for the findings that these patients were more likely to be white, they were more likely to live in an urban location, and they were also less likely to require additional government assistance beyond Medicare? Should we address that, or is this part of the fact that the criteria allows for that and they're being not treated on the H floor, but they're being treated on one of the other floors in the hospital unit?
I'll jump in first just to get the ball rolling on this. I think the couple things, very important question. Of course, we should address it. The reality is our state Medicaid agencies, for a whole host of reasons that are varied depending on the agency. We don't have universal. So when we turned on the waiver, it was universal. Every Medicare fee-for-service beneficiary was automatically eligible if the hospital provided the care. So we left it up to the state Medicaid agency to decide whether to opt in. And a decent handful of states have opted in, but like 10 or 11 or 12, something of that nature at this point. But it's not been universal, and I understand that, right? This is a temporary. So far, it was a waiver that was only going to last through the PHE. And then it had a 2-year extension. Hopefully, it'll get a 5-year extension. So there are reasons our Medicaid agencies are slower to adopt, but because of the patient population that Medicaid covers, that will help with diversity efforts a great deal. I would also say that every time though we talk about safety, there's always a cost, right? And so when I was at Medically Home, we would always, the criteria were basically, do you have running water and electricity? And if it was otherwise safe, everybody was included, and that was the zeitgeist. So I think that there are programs who are probably worried about oversight, as Lee refers to it, as program integrity, quality, safety, all those things, that may be more conservative about the types of things that must be true in order to have a hospital at home patient. So I think there's a lot going on. The last thing I'll say about what's driving that is a lot of the markets that are leading producers of hospital at home patients, like Portland, Oregon, for example, and others. They demographically helps explain some of the findings here. So I'll stop there.
Lee or Nancy, anything to add?
I think Lisa has hit the critical points on this issue. We need to know more. We need to recognize that there are differences across the states in whether the Medicaid program is paying for it, whether private insurers are paying for it, and that has contributed to some of the challenges that we see here in the report.
Mm-hmm. So shifting to some of the questions and comments from the audience and participants, one of the comments is that staffing shortages in hospitals overall are making staffing for hospital at home hard to support. Are there any thoughts on ways in which some hospitals are either currently addressing that or how that might be mitigated moving forward?
Most of the stories I've heard about this particular issue are from immediately past pandemic, where the in-hospital staff were burned out enormously. And to have something new, to have a new way to think about treating patients was a welcome change. To be able to do it virtually was actually something that helped retention enormously on the nursing staff. And we're also seeing that people are looking outside the normal flow of staffing, looking to others in the emergency responders in the area and others who can help provide staffing for these jobs. And that is something that you wouldn't do in the bricks and mortar hospital, but you can do outside and in ways that have really meant that it has been of benefit to many of the hospitals and health systems that have adopted hospital at home programs, even though several of them were worried about the very impact the questioner was asking about.
So Lisa, I'm gonna throw this question to you. There have been a few questions about the future of the waiver and what's the likelihood of it getting extended? Where are we in the process? But also the second part of that question is what's the likelihood of federal and CMS support for hospital at home to have patients admitted through ambulatory surgery centers and or other direct admit indications, if you want to take that as well?
Sure. So let's go to the first part first. We were just on the Hill for an event with the Bipartisan Policy Center Lee spoke at, talking to key staff members, key offices, and we came away with a positive feeling about the likelihood of getting an extension. The fact that the waiver is budget neutral is a critical factor in that positive vibe. I think the report is also a critical factor in that vibe as well. Nancy, you probably have heard very similar things. So I think that people feel good. Now, these are obviously topsy-turvy times in our politics, and surprises happen frequently, but talking to both Democrats and Republicans, folks in the Senate and the House, we're hearing the same thing. The duration of an extension is up in the air. Of course, but I'm also hearing positive things about 5 years, realizing that nothing, of course, is certain, especially in these times. And before I go to the second part, Nancy, did you want to, or Lee, did you guys want to weigh in on that really important question about the extension?
I'm hearing the same things you are, Lisa. The only difference might be that of late I've heard that it might get the very short extension, 3 months to get it over into the new Congress and let the new Congress decide whether it's a 5 or maybe longer extension.
That's a great point. Yes.
Yeah, and I helped with the Bipartisan Policy Center report. So I think we do need also to give the resources to CMS to evaluate this properly, as well as implement it properly. So I think getting back there, that probably adds small cost in the scheme of things. We're not talking about a lot of money. So I think that will be, they may consider that for that 3 month, because they probably don't want to, Nancy, as you say, authorize the study and the resources just extended until the new Congress can act.
Mm-hmm. And just to also add, like, I think I was probably less than clear. That's exactly what I'm hearing, is that the most likely path is that this is now considered a Medicare extender. So it's in an extenders package like telehealth. And folks right now, because of the outcome of the election, expect about a 3-month extension for all of the extenders. And then sometime in March is the likely time that they would have consider the longer term for both telehealth, and all of the other Medicare extenders. So that's tracking for sure what I'm hearing. To your really important question about sort of liberalizing, so we have this core. I think some people I think would say, hey, don't go so fast. We've only had one report from Congress. Let's take it slow and get more data before we even consider, allowing admissions from places other than the ER or the floor. Other folks see that differently. I do think it depends on what the next administration looks like. The next, this was an effort that began in the first Trump administration. There will be a second Trump administration. It is unclear at this juncture who will be leading it. We know who's been nominated, but I think whether or not the incoming administration really takes the ball and run with this in terms of that type of liberalization is a question mark that remains to be seen.
I'd just like to say one thing to the users group, actually. And as you think about this, which is, I always think about there's pressure saying you should do this, but the opposing forces, it's not getting to yes, it's actually getting past no. If we go to the Harvard negotiation course, and thank you, Lisa, for the comment about the fact that I have a master's in law, what she was referring to. So I actually think that the key issue is I try to channel many of the concerns. I think what is important now is to address those concerns and take them away in the way you would extend something or evaluate it so that we can answer those questions or we can decide, as opposed to, my opinion, making sure that those concerns are addressed in any extension of the waiver if we're going to expand it.
So there's a variety of other questions in that same realm about whether or not we could consider this moving hospital at home into postpartum units if for patients that medically qualify. Thinking about building this into pediatric care, obviously not under the Medicare waiver, but for those patients that are covered under Medicaid. But more broadly, if we were to think about commercial insurers, what are you getting as a sense of commercial insurers, either their interest in the model or the program and or their take up of it to date?
I can speak to some of that, and Nancy, I'm sure you can as well. I mean, I think it's like everybody else, takes a lot of resources to sort of, if you're a giant institution, which payers are, to kind of get your head wrapped around this and say, we're going to go in this direction when there's a question mark about the long-term viability of the model. So if we get, and I hope we get, a 5-year extension, I think that would accelerate uptake at the hospital level, at the payer level, all those things. So I think uptake has been stronger in markets where you have strong systems who are pushing for it, and less strong in other places where that's not the case.
And Lisa, you're right. I hear interest from private insurers in this. Most of that interest comes with a question of, will this save me money? And I think maybe is the answer that we have right now. This report suggests that maybe there would be if the insured population uses a lot of post-hospitalization services, but that would vary from insurer to insurer. I think what we can say honestly is that we believe from this and other data that it won't cost you more. It may save you something, but we believe the outcomes for those patients who qualify will be better, and that their longevity will be better as a result.
Another question that came in is maybe because of the comparisons that are being made across in the report, is why is identical care to brick and mortar hospital the goal? And if that's the goal, doesn't that take away the benefits of being at home, and instead shouldn't the goal be safety and quality?
So just to be clear, I don't think the goal is identical care. I think the goal is identical or better outcomes. Right. So and clinically at least as good as in the hospital, in the bricks and mortar. And we know from a lot of research that's gone on that patients who have chosen to do this and their families are often much more satisfied. So the two outcomes of interest, as far as I'm concerned, the clinical outcome and the patient's
And we
outcome.
didn't design it to be identical care. We just said, if you're going to be paid a hospital DRG, which is the way it was originally described, which includes GME and all the other payments. So one of the things to think about is, will we be training, which I think is important to do, our residents, especially if you're going to get GME in this setting, that again, Nancy, exactly how you defined it, the outcomes are the same. It's for the same acuity of patients having the same outcome of care with certain minimum requirements that for safety. But that's how the hospitals work, minimum requirements. If you can deliver, and they're actually relaxed. It was only, I still remember the debates. It wasn't 3 times a day. It wasn't a nurse. We actually, and that we got a lot of input from the hospital at home community that I eventually signed off on. Was the idea it could be some degree of paramedics. It could be some degree of virtual.
On the last 60 seconds of the panel, any final words, predictions under Dr. Oz, under RFK, and or just in general for hospital at home and the waiver? Start with you, Lee.
It's a great way to deliver care for a subset of patients who need hospital care, and I think it will be extended. And now it's up to the community to show its value, how it should be priced, and how it should be overseen.
Nancy, what would you add?
I'd only add that I think we need to have conversations with all sorts of device manufacturers, because I think new tools will really help us extend this opportunity to more patients who would benefit from it and really appreciate having that.
Great. Last words,
Oh,
Lisa?
I felt like I won. I just want to thank Danielle Adams and Dr. Ashby-Wolf for their extraordinary work to keep this program going. And the last thing I'll say is I am, of course, as a consumer, as a taxpayer, I think we should have payment that is appropriate. But please do not treat, if we make broad cuts in a payment, those will not have similar impacts across all markets. They will have disproportionately harmful impacts on the very people who are lower income, the hospitals who have high Medicaid populations. So whatever happens in the future, please let's keep that in mind, so we don't end up taking away this option for the communities who should be included in those who get to enjoy the benefits.
Well, Lisa, Nancy, and Lee, thank you all very much. And thank you to the participants. And Gabby, I'll hand it over to you for final words.
Thank you again, all of you. That was a great, rich discussion. As a reminder, we have an upcoming ongoing users group caregiver study. You can scan this QR code or contact us at info@howusersgroup.org. And we also have our HA minimum data set project. Programs will receive benchmark data and will be able to compare their responses to all HA programs. You can scan that QR code. Again, you can join our watch our entire webinar series on our website. We have this is our 26th webinar. And you can get more information at our website, www.howusersgroup.org. We have lots of technical assistance on our Technical Assistance Center, and we have a new featured resource, Clinical Response to Systems Downtime Guide. And lastly, we'd like to thank the John A. Hartford Foundation and the American Academy of Home Care Medicine for their ongoing support.